And as many of you will recognize or appreciate, any attempt to sustainably improve equitable access to quality pharmacy services must include strategic considerations of how to effectively leverage retail drug outlets, specifically pharmacies and drug shops. These outlets are often the first or only point of contact for health services, particularly in rural areas in some low and middle income countries. And so with that in mind, MTaPS is hosting a 5-part webinar series to explore the theme of advancing equitable access to quality pharmacy services through retail drug outlets. The ultimate aim of the series is to help highlight existing policies and strategies that can be used as elements in defining a pathway towards more equitable access through the private sector. Today's webinar is the first in our series, and we will be focusing on the promotion of good pharmacy practice. And with me, I have a very esteemed and dynamic panel. Catherine Goodman, professor in health economics and policy at the London School of Hygiene and Tropical Medicine. Azad Kalam, director of the Better Health Bangladesh program. Mohamed Lukwago, manager of the Central Region in Uganda's National Drug Authority. Edson Irita Munanura, lecturer at the Department of Pharmacy at Makerere University and secretary of the Pharmaceutical Society of Uganda. And our own Birna Trapp, country program director, USAID MTaPS Nepal. We're sharing a brief bio for each panelist in the chat so you can read more about their backgrounds. In the interest of time, we'll forego any extensive introduction on overview of their backgrounds. So what to expect over the next, say, 85 minutes? We will start with a couple of basic foundational questions to get all of us on the same page. Then we'll expand our discussion to consider the status of pharmacy practice and some of the equity implications. And so in all, we'll have about 45 minutes of a panel discussion, about 20 minutes of dedicated audience Q&A, maybe 25, depending on how we do with time, and about 15 to 20 minutes of summation and close out. Please treat this as a conversation. So submit your questions as we go along, and where possible and relevant, I will try to weave those into the panel discussion. Otherwise, we'll try to get to them during the Q&A. And with that, let us get started. And we'll start with some very basic foundational questions. So over to you, starting with you, Catherine. In its simplest terms, what does equitable access to pharmacy services mean? What would you describe as some of the essential elements and dimensions of equitable access?
Great, thanks Tamara, and great to be here. I suppose we could think of equity along a number of dimensions. Of course, there's socioeconomic status and geographical location. There's also gender, disability, treatment of stigmatized or sensitive health conditions. So they're all important dimensions. And perhaps one we tend to think of first is around equity of access and socioeconomic status. It's often one that comes close to our mind. And I think it's important to start by saying that the pharmacy sector is already hugely important in equity of access for poorer groups. So we see in many countries that use of pharmacies, or more particularly smaller drug shops, are responsible for a really high proportion of care, particularly among poorer groups. So they are already providing a substantial proportion of treatment and make a real difference to equity of access. And that's often because for poorer people, they can be nearer to home, they can be quicker, which is really important when taking time off work means loss of income. The costs can be lower. They often have very reliable drug supplies. And then for some people who feel any stigma in seeking care, that can also be a really useful place to go. But while we recognize that pharmacy sector is really widely used by nearly all socioeconomic groups, I think a key question we want to come to today is that it's not just equity of access, but it needs to be equity of access to quality care. And crucially, that's going to be looking at what the quality of medicines are that people can find in the pharmacy outlets that they use, but also the appropriateness of the services they receive. So how is the dispensing, how is the advice, how is the counselling, etc. So I think that those are some thoughts to start us off.
Thank you, Catherine. Very well said. Anything to add to that, Birna?
Yeah, I think I of course totally agree. And especially when you live in a developing country, it's so easy to say equal access, but when you live on a mountaintop compared to in a lowland, there is hugely difference in the services you can expect. And there will be pharmacists in urban areas, but not in rural areas. And when we then talk about what it's all about, quality of service, the quality of good pharmacy practices, in some countries, it really does not exist, with no pharmacist or poorly educated pharmacies, with availability of very few medicines, and when you have to pay for it. I mean, these things, when you take the financial dimension into it, it really becomes a challenge to say we have equitable access to pharmaceutical care. And I totally agree that it is critically important that we have equal access. But for some countries, including Nepal, it really is a far dream from where we are now. And I think what we have to realize is that the challenges are huge. And it's not just developing guidelines for GPP, because the implementation is tremendously difficult. So when we look at this concept, and I think Catherine also highlighted it, to the many dimensions there is in equitable access, they are all interlinked. You can't resolve one without it influences everything. And you have to have a holistic approach. And to get that, it's not enough that the users or the organization, professional bodies, or will really do something. It really has to come from the top. It's about leadership and policy and regulation if we are to make any impact on this. So that's my contribution on this point. Over.
Thank you, Verna. And I think that segues really nicely into a follow-up question around good pharmacy practice. And could you speak a little bit to its centrality in ensuring equitable access? Yes, to you, Verna.
Okay. Yes, I mean, why is GPP so central? The way I see it is that in many areas, regulation, for instance, WHO have started saying we need a global benchmarking tool so we can assess where we are. And it's exactly the same with GPP. It's an agreed way where we can say this is the standard we are aiming at. And the moment you formulate these international standards, then you have a great starting point to say, where are we and where do we need to move? And what we have been doing both in Uganda and elsewhere is trying to practicalize these GPP into indicators, so that we have set a number of domains that should be measured, like pharmacy staff, premises, service quality, dispensing quality, information, all those things that we know are part of GPP. They are formulated into a number of indicators in domains. And then we have decided whether we have critical indicators, major indicators, or minor. And the critical indicators, they must be passed to be licensed. And the advantage is that when you start off, where, for instance, in Nepal, you don't have everybody trained as pharmacists. Okay, so that cannot be critical to start with. But then maybe in 10 years from now, you could say, okay, now we can accept that everybody should at least be pharmacists to run a pharmacy, and then it becomes critical. So you can modify your indicators without really changing them, but changing the level. And that allows you to compare, as we are doing now with Uganda, who have also used those indicators, and other countries, both to see where are you, to see if your intervention strategies help, do we improve? And I think that is critically important for addressing pharmacy services in a longer term. It's what is needed to move it forward. However, it's of course not every aspect that are addressed when we talk about equitable access to pharmaceutical services. We are not looking in GPP that are there equal number of pharmacies throughout the country. That's not assessed in GPP. Affordability is also not indicators that are assessed. There are other tools for that, and there are other ways, but it's not part of GPP, and that is something one could think of in the future. We often tend to neglect the financial aspect, and it is critically important. Pricing mechanism, price regulation, affordability, it's so important not to forget that. Or
thank you, Brenna. But the financing piece of it, of course, is without question equally important. But I think you've touched really well on what our program director Kofi often talks about, the 3 Ps, people, premises, and product. And in conversations we've had leading up to this webinar, Franco Fuller had a conversation with him recently, and he pointed out that we have to think about the 4th P as well, which is implied, and that is around the practice piece of it as well. Edson, from your perspective as Secretary of the Pharmaceutical Society in Uganda, anything you want to add with respect to the centrality of good pharmacy practice in ensuring equitable access? I think you're muted, Edson.
Thank you, Tamara. GPP is centered on ensuring improved patient care. So the centrality in access to pharmacy services therefore covers areas to do with the safety of the product, as has said, that the clients or patients are able to access safe and efficacious medicines, and then also looking at access to trained healthcare providers across board, and then also the other services that pharmacies or pharmaceutical outlets are able to offer in terms of monitoring vitals like blood pressure, the patient weight, and blood glucose, etc. So I think Bina has said it well, and when you summarize it with the 3 Ps, yeah, it comes out really well in terms of the product and the premises, and then the practitioner. So that across all boards, irrespective of whether it's a gender barrier or it's a physical location or that the services remain uniform across board. And that is the way it ensures equitable access to pharmaceutical services. Thank you.
Thank you, Edson. Anything to add to that, Mohammed, from the regulator perspective in Uganda?
Thank you, Tamara, and thank you, Bina and Edson, for that good introduction. I think they have said most of what is important in that area, but on the dimension of cost, where pharmacists are available in those outlets, it helps a lot because they make decisions that optimize the care for those patients within their financial statuses. In urban areas, people have enough resources so they can access medicines. But in the rural areas and upcountry areas where their economic status is not that good, you find that if the pharmacist is available and they can make good decisions, they optimize, and that improves the access in the dimension of cost. But also from a regulatory perspective, the strength of the regulation ensures that the people who are supposed to be there are there, and they make the decisions that benefit the patient. Like, we know GPP is centered on responding to the needs of the patients that use the pharmacy services and optimizing the services and giving evidence-based solutions. So availability is key, and regulators can also play a pretty good role in ensuring that the people are available and can give the service as best as possible. Thank you very much.
Thank you, Mohammed. And I think that touches a little bit too on the importance of when we look at geographic accessibility, because the choices that patients have to access pharmacy care also has impacts, I guess, on the quality and the incentives for providers to ensure that they're providing good quality services, and also in competition and the impacts that could potentially have on cost as well. So we want to, we kind of have a little bit of sense now, I think, in terms of what we mean when we talk about good pharmacy practice and what we mean when we talk about equitable access. So I want to pivot a little bit and think and move the discussion towards a broader discussion around, or a broader consideration around then what the landscape looks like. So what does the private sector landscape look like, and what, what's its role in pharmacy service provision? And we have a very balanced panel here, so we'll get a bit of the country perspective, but we can also get a bit of the more regional and global perspective. And Azad, we will start with you as the director of the Better Health program in Bangladesh. Can you briefly just provide an overview for us of what the private sector looks like with respect to pharmacy care provision? Over.
Yes, Tamara, thank you so much. And I also appreciate for organizing this webinar on an important topic. So I like to say that to understand the private sector landscape of pharmacy services in Bangladesh, we should understand the country context as well. Bangladesh is a small country with a huge population of 170 million. And about 1,100 to 1,200 people living per square kilometer. The country's land area is mostly plain, so good road communication, electricity, and cellular network are widely available across the country. There is a structured and well-distributed public health facilities across the country, although primary healthcare system in urban areas is weak, where 30% of the population live. That means in the urban area, 30% of total Bangladesh population live. The Ministry of Health and Family Welfare in Bangladesh has about 20,000 public health facilities in tier distributions and in 5 administrative hierarchies. Of these 20,000 health facilities, 19,000 are daycare facilities and 1,000 are hospitals of different types, primary, secondary, tertiary, specialized, super specialized. To get service from the public health facilities, the people require no or minimal user fees. And once actually they provide this minimal user fee or no fee, the medicines are free. However, the medicine lists differ between the tiers, different kinds of hospitals or facilities. This picture sounds good, but the truth is, the reality is roughly 30 to 40% of the people go to the public facilities. And the rest of the people, they go to the private facilities. And the drug shops, particularly the retail drug shops, are often their first choice. The private healthcare sector is strong in Bangladesh, mostly for profit and comprised of private hospitals, clinics, doctors' private offices, thousands of retail medicine shops, and diploma and informal healers. According to the National Health Accounts of Bangladesh, out-of-pocket health expenditure is 67% of the total health expenditure. And 69.4% of this goes to medicine. Regarding the pharmacy services, we have a drug administration. It provides license to about 156,000 drug shops, of which 90% of the community pharmacies. It is estimated that there are another 160,000 unlicensed drug shops. That means more than the number of the licensed drug shops. So a total of 316,000 pharmacies in Bangladesh. The drug administration does not have enough workforce to monitor these large number of the drug shops. So actually, this is the landscape of the private drug shops. And maybe there is another question, because we have a good service about the accredited drug shops. So if Tamara is interested, I can actually...
Yes, Azad, could you just, for the audience, in just a minute or two, just quickly touch on the work that the Better Health Bangladesh program is doing in terms of the accreditation of drug shops and how that's helping improve quality.
So thank you, Tamara. MSH in Bangladesh, through our project Better Health in Bangladesh. It provides technical assistance to the drug administration since 2018. And the purpose is actually improvement of the retail pharmacies in the country. Our donor is FCDO, the Foreign, Commonwealth and Development Office of the UK government. Earlier, actually before the start of our project, the Drug Administration did not have any standards or well-prescribed guideline for inspection and licensing a private drug shop. It only looked for presence of a municipality trade license, a premises, and an affiliation with a registered dispenser. So one dispenser would affiliate himself or herself with more than one drug shop. Our project helped the Drug Administration to develop a standard accredited drug shops named the model pharmacy or the model medicine shop. These standards cover 11 areas, and these include personnel, premises, dispensing, storage of medicines, hygiene, record keeping, documentation, disposal of damaged and expired medicines, allowable products and services, pricing of pharmaceuticals, reference materials, and offenses and penalties. We also helped developing an inspection, monitoring, accreditation strategy for this purpose. So actually, this is the book, which actually covers all those details of the 11 areas I have mentioned. With our assistance, the Drug Administration provided accreditation to the first set of 2,193 private medicine shops in 2019-2020. The target for year 2022 is to accredit another 4,000 drug shops. So the good news is, being motivated, the Drug Administration by itself recognized another 16,000 licensed private drug shops as the model medicine shops. So what is the accredited drug shops? In our program, the accreditation process requires several steps. For example, we do the pre-assessment of the private drug shops for minimum of 3 criteria: whether they have a drug license, a full-time registered dispenser, and a standard premise with minimum of 120 square feet floor space. Then Better Health in Bangladesh provides the dispensers of the selected drug shop a prescribed training on GPP. And we have a curriculum, standard curriculum for this, this book. Here is the standard curriculum. So on completion of the training, the drug shops and the dispensers get a window period to raise the standards of the premises and their practices to the desired in all 11 areas.
So, if I may interject there, thanks for that really quick overview of the accreditation program that you're running. But we also want to hear a little bit from Uganda and how that compares to what you've outlined in the case of Bangladesh. So in Bangladesh, we have a very robust private sector and playing a strong role in the provision of services. Edson, can you speak a little bit to what the situation is like in Uganda and what the role of the private sector is there?
Thank you, Tamara. Uganda and Bangladesh are not far away from each other. We have around 1,600 retail pharmacies, and then the ones that we call drug shops here, the Class C, the majority around 13,000. Now, Uganda runs a private-led sector economy policy. That means that government has little input in how these outlets work in terms of financing and all that. Just provides a regulatory framework through which we work. Now, of course, majority of the public go to public facilities for health service provision, healthcare services, but they procure the medicines from these drug outlets. And of course, the Class C shops or drug shops are the ones which have deep penetration to the rural. But then those ones have a limitation in terms of the services they can provide. First of all, they are limited to Class C medicines. Those are the over-the-counter medicines. The personnel are usually lower cadre. And also the issues with the premises and the others. When we look at the 3 Ps, we're talking about they're really low in terms of the services there. But in a large aspect, we're looking at the private sector under these pharmacy outlets providing the products to the people, acting as areas of triage to decide referral, manage these mild ailments, and then do monitoring of adverse drug reactions and then monitoring of vitals. So they play a big role in terms of provision of medicines to the community. I don't know if I should say what Pharmaceutical Society of Uganda is doing.
Sure, but keep it very brief.
Originally, we were working with NDA on having drug shops accredited in the rural areas, but the drive with the National Drug Authority is to have retail pharmacies out there, because these are the ones that have a pharmacist, and the pharmacist is able to improve the quality of services in line with GPP. So for us at the pharmaceutical side of Uganda, we do GPP audits, but for retail pharmacies and the wholesale pharmacies, we don't go to the drug shops. So Dr. Lukwago will talk about the GPP in line with the drug shops. But as been had raised earlier, we look at premises, we look at regulatory compliance, we look at documentation, the personnel, and then storage, and the distribution and procurement, and then professional services provided. So we look at 6 key areas, and we've assessed them, and we know that in terms of performance, we are really doing badly. I don't know if that will come in the next question. I have some numbers to give you the idea of how we are performing in that area. But that is it from me here, Tamara, for now.
Thank you, Edson. And Mohammed, would love to hear from you from the regulator's perspective. There's actually a question in the chat from Lani. How do you ensure that small private drug shops get licensed, and what are practical incentives and levers that have worked in a country like Uganda? And while answering that question specifically, would also be good to just get your take on regulation of across the private sector in its totality, if you can, and what the context is like in Uganda. Over to you, Mohammed.
Thank you very much, Tamara, and thanks, Edson, for that background about Uganda. Like Edson gave you the statistics, that's pretty much that we have in Uganda. How we license the private dealers, we classify them at different levels. We have the drug shops at the lowest level, which are the classic drug shops. They sell the over-the-counter medicines. We allow the lowest cadre to be a nurse, either an unenrolled nurse or registered nurse. Although the most preferred professional there is a dispenser or a diploma in pharmacy. And they stock classic medicines. The next level is the pharmacy, which can stock all the kinds of medicines. Now, because of the dynamics of the country, you find that pharmacies are more in the urban areas and less in the rural areas. So you find that most of the rural areas are served by the drug shops, and it's a bit of a tall order for us to ensure that there is compliance, which translates into good GPP. They're supposed to be stocking Class C, but end up stocking more than the Class C. Stock some antibiotics and other medicines. And we had a project some years back for accrediting some drug shops in rural areas by giving them training, quite similar to what Azad just explained. Give them training, we teach them about managing of finances and all those things that help the business to thrive. And then we have a certain list of drugs for which they have been trained to use for the illnesses that are common, like malaria, pneumonia, and others. And then we give them we allow them to have those medicines. And there's a monitoring process for them to ensure that they are recording, they are upholding the standards so that people can have access to those medicines. But for the pharmacies, we ensure that they maintain the proper standards through regular inspections. We hold an inspection every year. Now we have increased the validity of our license period. It used to be 1 year, now it's 3 years. And that gives us enough time to continue doing the support supervision, in which we train them on issues where we think they need to improve. We also identify areas of concern, which we address through sensitization meetings and trainings. We also go to check on the medicine quality and to show them how they can also be involved in checking on medicine quality through those regular visits. But we also do enforcement, because regulation is nothing but enforcement, even when you do all the sensitization and giving them the carrot. At some point, you need to pull out the stick to ensure that whoever is not complying is put to book, and to weed out illegal outlets.
So thank you, Mohammed. So you talk about, it's all about enforcement. And so Edson, I want to come back to you a little bit, because I know that you do these audits and you can make recommendations, but what happens with these recommendations? And can you speak to the extent of the collaboration between PSU and the drug authority in ensuring actual enforcement?
Yeah, thank you, Tamara. Yeah, we do audits, we call them supportive supervision. The Pharmaceutical Society of Uganda has regional representatives in the different regions in Uganda who help us go to these facilities and do the audits based on the 6 parameters I mentioned earlier. Now, of course, the idea is to have all the pharmacies at the same standard. And now, because of challenges with finances, we decided to we usually concentrate on the ones that are lagging behind. So we have a category of those that score above 75. We put them in the green category. That means those ones don't need regular supportive supervision. Then we have the ones between 60 and 74, orange. Those ones, if funds are available, then we have the ones in red, the ones score 60%. And those are the most of them, actually, around 60% of the pharmacy outlets we have are in the red category. That means they are non-compliant in terms of that. So working with NDA, this is what we do, the National Drug Authority. One is we use the same supervision book. So when we go to the facility, we look through what comments were raised by the inspector from National Drug Authority. We engage the staff on that, and then we also make comments there. That's one. Number two, we also tried out going with the NDA team. When they are going for their supervisions, we also go there, we tried out that. Then when we identify gaps, we do trainings for the auxiliary staff, the non-pharmacy staff who are in these retail pharmacies. Originally, we used to do it centrally in Kampala here at the center, but now we've chosen to do now the trainings at the regional level. And then the other thing we do is to ensure that on the audits, when they are being done, the pharmacist is around, because that is the technical staff, the director. So the person needs to be around so that, and then the owner of the pharmacy is also notified, so that whatever issues are raised are explained to both the pharmacist and then the pharmacy owner. And then we also agree on timelines and then write action points, and then we follow up on the action points with calls and all that. So working with the regulator, National Drug Authority, is good because we are all concentrating on the 2 things. We are 3 things actually: the product, the premises, and the professionals. Works out well in that National Drug Authority has the enforcement, has the law backing them. For us, ours is advisory to the team, but when you engage National Drug Authority, then they're able to enforce. If somebody is not compliant, then they can get a warning or they can be asked to close. So basically, that's what we are doing. But of course, we are struggling, as I've said, around 60% of the pharmacies are still scoring just above average, and that means we have a lot of work to do. Yes, I don't know if I've said it all.
So thank you, Edson, for that. You've outlined what I think is somewhat of a very hands-on, labor-intensive process in the supportive supervision. And you've also touched on the issue of financing and some of the incentives for compliance among pharmacies. So I want to kind of turn things back over to Birna, because I think a lot of this is built around the work that Birna led in Uganda on the SPARS approach. And so, Birna, maybe you can talk about this a little bit. And Edson mentioned that there's still, a lot of challenges, given that you have 60% of the facilities being non-compliant. So maybe touch a little bit on what some of the challenges are with that as well. Over to you, Birna.
Thank you very much. I think it's great to hear, and I think 60% is not bad. I'm sure when we have done monitoring here in Nepal, if we could score that 40% will pass a DPP inspection, that would be very, very good. So be encouraged to continue the great work. I think it's also important to recognize that the way that Edson and the association has developed a strategy. It's a multi-pronged strategy, and it's the same that Uganda has used for building GPP capacity in the government sector, where you combine capacity building through supportive supervision, but there's also some regulatory aspects. So it's capacity building, it's regulation, it's finance, and it's managerial, where you assess and use a tool to assess where you are, and that could be the GPP tool or the inspection tool. You have a targeted supervision and mentoring. You track where you are, what you agree to, and this about involvement of the leadership. That was some of the things we found was critically important for making sure that there was progress to be monitored. And then moving forward with the financial incentive. One of the things is for wholesalers, I mean, now I'm jumping a little, but for them to be part of a tender process, they need to be passing the skills. And there in Uganda, we actually try to involve the community. I don't know if Lukwaku can remember that, but we did some strategies to make awareness in the community about what is a pharmacy that has been GPP certified. What can you expect? What are the services you should be expecting? I don't know if you remember any of that and can talk about those strategies. Just a question, Lukwaku, if you can say something on that.
Thank you, Bina. I remember we had that initiative on GDP for wholesalers, and the wholesalers were very happy and enthusiastic about it. We began that movement around 2013, and we started implementing, and we got some traction at the beginning, except along the way, because of not fully implementing the entire tool, because we started broke it down into bits, and we first looked at the service areas and the storage areas of the systems, and that's what we did for the starters. But as the numbers have grown and the amount of work, as well as the number of pharmacies and inspectors, there has been a bit of scale down on how deeply we can implement it. And the recent assessments have shown that there has been a reduction in the quality of the service at the wholesale level in terms of the GDP parameters. That is something that we are trying to reawaken now. And together with the PSU, we had a training for all pharmacists on GDP, because notice that was one of the biggest challenges, that pharmacists that are coming on board did not get the training in school. The pharmacy school has also initiated some regulatory trainings at the undergrad, so that people can understand the GDP concepts very well before they come out. So it's a multifaceted approach to ensure that the professionals know what to do, and they keep monitoring, doing self-regulation, as well as regulators trying to reinforce the same during our visits and our enforcement campaigns. Thank you.
If I may say something,
Yes.
Tamara, when I look at this multi-pronged approach, where we have regulation, managerial aspects, educational aspects, and the regulatory aspect and financial, the regulation to me is the most important. You can often do a lot of training, but it might not be very effective, and it might not be implemented. That's where the regulatory strategy is the most important. But what I realize is, when I look at how we worked in Uganda, at that time, the regulatory body was not as strong as it is today. And one of the biggest changes to me was that the regulatory body, the NDA, became an autonomous body. That meant that they could hire and fire even as semi-autonomous, and they could be able to keep staff. I mean, Lukaku was still there when I was there, he's still there. And I mean, that means you are able to pay salaries, give conditions to work that keeps people still interested in staying with the regulatory body. And that is critically important. When I look at Nepal, where we're working now, strengthening the regulatory body is really a challenge because they are under the Ministry of Health. And that doesn't give them very much leave room. It does not enable them to strong leadership. And that makes it very challenging to implement good pharmacy practices. I don't know if I mean, it's because implementation of GPP, the first step is, of course, to have the guidelines. But in many countries, you have the guidelines, and then you realize they are not implemented at all. And that's where Uganda, I would say, has been very successful. Even 60%, as mentioned earlier, is not bad. I mean, it's moving forward. And if you look at it, what do you think, Lukaku or Edson, are the reasons why the regulatory body has been so much successful in Uganda? Or
I think that's a very good question, especially because, as Azad mentioned in his response, kind of describing the situation in Bangladesh, that there is evident political commitment from the government in having strong regulation, and they see it as a priority in terms of accreditation and such, having accreditation. So if you could speak to, I'd like to expand this question to Azad as well. So we'll start with Edson or Mohammed, and then turn it over to Azad to speak a little bit to what you see as some of the key factors in having this strong regulatory component being active and helping to move this along. Over.
So you are asking me?
Yes, we would like to hear from you as well.
Okay, thank
yeah.
you. Okay, so actually, as Birna has told, that many countries have the guidelines, but these are not enforced. So in case of Bangladesh, we can say that those medicine shops which received accreditation from the Drug Administration, so actually they strictly adhere to the guidelines of the Drug Administration. So this is the good point. And here the dispensers of those medicine shops, they are trained on good pharmacy practice, and they follow the pharmacy laws and the regulations. They don't sell damaged, falsified, counterfeit, substandard, or expired medicine. So there are a list of registered medicine by the Drug Administration, and they don't sell medicines without actually enlisted by the Drug Administration. So there is a list of prescription-only medicine. So they sell prescription-only medicine only with prescription, and they don't sell antibiotic without prescription. There is an MRP, maximum retail price by the Drug Administrations, and they follow this. And they also advise the patient to actually.
Sorry to interrupt Azad, but what's the incentive? What's the incentive? Okay, so you seem to be having high compliance.
Yes. The incentive is that actually, people from all walks of life, they go to these kind of drug shops with accreditation, and they have got the confidence, and they understand that they will treat the patient freely, they will distribute the quality medicine, as well as actually they will provide adequate advice to the patient. There is a counseling system in that cases. So, people have more confidence, more and more people are going to these drug shops. So this is actually creating a business model for the sustainability. So other drug shops, which are actually not accredited, they are actually showing their interest to us that they want to be accredited. So, these are the incentives. And yeah.
Great. And then, so we hear a little bit about incentives for the retailers themselves. I want to flip a little, go back a little bit to the earlier point from Birna and hear from you, Edson and Mohammed, about, it seems then that there has been a lot of progress in the strengthening of the NDA and its capacity to regulate these pharmacies. So can you speak a little bit to what you see as some of the key factors that enable this strengthening?
Should I go first?
Sure.
Okay. Thank you very much. Well, the institution has grown over the years. The number of inspectors has increased. We used to be a couple of inspectors, but now I can say regular inspectors are over 60, spread out in the different parts of the country. The facilities for doing the inspections has increased. We have enough vehicles now. We have more resources at our disposal to do the inspections. And the collaborations as well between the other agencies, like the PSU, have also increased, so that we can be able to synergize our activities and be able to achieve more. But also the leadership is key. The focus of leadership is also important. There's been a focus on ensuring that the pharmacy services are improved. And that has definitely been an important factor for us to have enough traction in this area. Working with the schools as well, I can't overemphasize that. We are more present in the pharmacy schools now to try and ensure that we mentor the newer generations, to try and improve the service delivery. Together with PSU, we come up with the requirement. In Uganda, a pharmacist can supervise 2 pharmacies. So initially there was an issue of long distances between the 2 pharmacies supervised by the same pharmacist, but we agreed that we limit the distance to 100 kilometers. So we try to work together to police and ensure that people do not exceed those distances. So that in a way improves the presence, but also improves the service delivery. I cannot leave out the issue of enforcement. The enforcement arm of NDA has been strongly enforced. We now have a fully fledged enforcement department with commissioner of the police and other police officers who have their daily job of ensuring that they look out for non-compliances and they keep, of course, they work with inspectors, ensure that whoever is not working well is put to book. So
Okay.
Multiple factors have really contributed to the kind of success we've had over the last few years.
Okay, thank you, Mohammed. So we've gotten, I think, a good picture of the situation in Nepal, in Bangladesh, and Uganda as well. And I want to turn back to you, Catherine, more at the regional, global level. What do you see as some of the key challenges around the pharmacy practice in the private sector?
Great. Well, thanks. I think the others have really talked to a lot of these already. And whilst, well, there's so much variation. There is variation in pharmacy retail sectors across context, and it's really important to be cognizant of that. I think most people will recognize those challenges in these types of contexts that you've already described. So I think some of the ones we've talked about so far have been around quality of medicine itself and the product. And we do know that that is a huge challenge. I know that your national drug authorities will be looking into this, and whenever studies are done, we have anything from sort of 5 to 30% of medicines with quality challenges. So that's a huge issue, and one that really needs to be addressed. And I think as Edson maybe answering one of the questions in the chat about this, about quality of medicines, emphasizing the importance of doing that further up the supply chain. It's very difficult as a drug shop owner to know what you're being bought, let alone a patient purchasing. So I think that's one key area. Then you've talked quite a lot about the practices and the different issues and challenges there are there, about the degree of adherence to regulation, the problems of non-adherence to regulation in many settings, but also the challenge you have in balancing access, equitable access, and appropriate restriction and stewardship. And I think we see that particularly in prescription-only medicines. But also in the, as I think you described it, sort of the minimum criteria for licensing. And I can see that in these countries, as in others, you're looking to kind of tweak that to try and keep the access and work within the resources you have while still trying to provide care to a good standard. So those are some of the challenges. I just wanted to go into one new area which we haven't touched on yet, which is really the digital revolution that's coming in pharmacy and the challenges that brings, but also the opportunities. So most of what we've talked about in the landscape so far has been bricks and mortar, what we might see if we drive around in Uganda or Bangladesh in terms of passing pharmacies and passing drugstores. But now so many things are going online, and just some of the developments that we're seeing more recently. Of course, we've got online pharmacy, e-pharmacy. Sometimes that's the brick and mortar pharmacies doing home deliveries or at that end, but other times it's national or multinational firms operating purely online. So we might not see them at all. And then within pharmacy, we've got loads of other new digital developments. So we've got electronic point of sale technologies that can really support pharmacies to manage their stock and also can allow better monitoring. We've got digital platforms that can link with health insurance, which could be very important as national health insurance expands. You can use mobile money to subsidize, target subsidies. And then talking, I think as Edson talking in the chat about traceability of products in the supply chain, we've now got digital technologies like blockchain that can help us do that. Now, I don't want to suggest that this is all happening everywhere, and particularly in poor rural communities at the moment. But I think going forward, these changes are coming, and some of them could actually really help us strengthen the quality of pharmacy services. So I think as we look at our current landscape now, we also have to be looking at those changes and innovations. Over.
And I think that's a nice plug for one of the webinars in our series. I think the third one on June, in 2 weeks, touches on some of this. And but I think you make a very important point, Catherine, around, this landscape is changing. And so I'd like to hear from perhaps from you and maybe from Azad and as well, or even Mohammed. What do you see as some of the implications in terms of equity around this changing landscape? Given what we know now, we know about the current role of the private sector. What can we anticipate in terms of equitable access or the impact on equitable access? So we'll start with you, Catherine.
Yeah, I mean, in some ways you think of online pharmacy, you think, well, isn't that the purview more of the middle classes in the urban areas who are doing that now? Does that have that much effect on poorer rural groups? And I think that probably is the case to some degree at the moment. But looking forward, there is potential for these technologies to actually have a positive impact on access. You could imagine that if you have a chronic condition, hypertension, for instance, that you need regular supplies of medicines, it would be very important to be able to get that in an affordable way. And if you could do that in a well-regulated GPP manner that was delivered to your door, that could be very valuable to you. E-pharmacy can also be important for stigmatized conditions, for instance, could also be anything sensitive, could also be important. And there are other ways that this could potentially improve quality of services as well. On the other hand, we're also making people potentially vulnerable to exploitation, particularly by rogue online pharmacists providing poor quality drugs and inappropriate provision of medicines without proper safeguards. So it raises a whole lot of challenges, and I think raises challenges for us as the regulators, always having to catch up with what the market is doing. And so really thinking about what your regulatory team needs to look like in the future and what skills you need. Maybe you need to borrow from your e-commerce regulators to help you keep up with these new developments and ensure we're getting those potential benefits to access going forward.
Thank you, Catherine. And then for you, Mohammed, related to this question, in the case of Uganda, some of these innovations that Catherine has mentioned, I don't know how prominent they currently are in the market, and if the NDA has given any consideration to how they need to be shifting their strategy to keep up with these innovations. Any quick thoughts on that, maybe in 2 minutes or less?
Thank you, Tamara. The changing landscape is definitely something we are trying to observe and respond to. It becomes so so important for us to think about online pharmacies at the height of the pandemic, where there was total lockdown and people couldn't move. There were big challenges in access to medicines. In Uganda, we have a certain mode of transport. I don't know if you've seen it anywhere else in the world. It's called boda boda. These are motorcycles that they move people around. They're very, very important in trying to deliver medicines to people for their refills. Some were HIV patients, others are chronic conditions. Access was pretty difficult, but they were allowed to move because they were delivering food and other items to people. So at the height of the pandemic, the authority instructed us to come up with some guidance on online pharmacies. We developed a guideline, which was approved by the authority, but then realized that there is a gap that we have not filled yet, and that is a proper guidance on transportation. So we have halted implementation of the guideline on the pharmacies. We're developing a regulation on transportation, which will be comprehensive enough to also look at the modes of transport and how we can guide on the companies that are delivering medicines to people through the online pharmacies. But we've had some trailblazers in our industry. There is one pharmacy that has really shown the Ugandans that it's possible to be done, and they're doing a pretty good job. Although we don't have a proper legal framework yet, hopefully as soon as we get the transportation guideline out for the regulation, we'll be able to guide everyone and provide the necessary mechanism for us to be able to get medicines through the online pharmacies, but as well as controlling what Catherine talked about, the counterfeits and falsified medicines, which seems to be a very big problem in the West, where online pharmacies are prevalent.
Great. Thank you, Mohammed. And then over to you, Azad, where I know the government of Bangladesh, for example, is a big, embraces technology in all aspects. I was wondering, Catherine has touched on the importance of e-commerce. Mohammed in his submission just now kind of pointed out the need, for example, thinking about transportation. So the regulation and the emergence of these different kind of innovations, e-pharmacies and such, it's not just a Ministry of Health concern. You're going to need Ministry of Commerce or Finance. You're going to need Ministry of Transportation or whatever infrastructure ministries there is. It's to the extent that you can you speak maybe in 2 minutes or so a little bit on what you see as the changing landscape in terms of the private sector, to the extent that you can, and what the approach has been of the government in trying to kind of keep up, or at least in some ways, I guess, get ahead of, if possible, the needed regulation.
Okay, thank you very much. So first of all, I actually like to add that in Bangladesh, actually Bangladesh has a digital Bangladesh mission, and all the sectors, including health, they have got actually very significant presence of health and actually use of the digital health. The drug administration also actually digitized its process, like automated licensing and renewal system, as well as pharmacy management system. Okay, this is one side. But I have mentioned that there are many drug shops in Bangladesh. So the drug shops are widely available across the country. So actually the online pharmacy, this is really in the initial stages, and the drug administration is only actually allowing those pharmacies actually to do this kind of business, which are model pharmacies or actually standard practices. But I see that actually this has got both the positive sides and the negative sides if it is actually cannot be regulated. But regulation is also very difficult. Positive side is that this is easy. People can order the medicines from their home, and they can actually order medicine not only for them within the country, but from outside the countries. And in Bangladesh, recently we have seen there is a huge boom of e-commerce. Actually for medicines, this is not that significant, but for other areas, this is quite significant. And there are many scams about the actually e-commerce site. And now, people actually can buy medicines from other countries. People actually, fraudulent people can sell medicine even from within countries. And this can go beyond the knowledge of the regulatory authorities. And how actually this can be tackled, this is a big question. And I believe that it is not possible by a particular country to address this situation. Rather, globally, these challenges should be addressed, and we should have to have a actually good solution out of this. Actually, this is my observation.
Thank you, Azad. Edson, over to you.
Yeah, Tamara, I like the discussion about the e-commerce and all that, but it will still be targeting some kind of segment, and that is the people who can access the telephones and have the data and then are able to make the purchases. But in line with equitable access, whatever a good pharmacy practice, one we could say, has improved to a large extent. But when you look at it in the rural setting, the challenges are still there. For example, in Uganda, getting premises that meet the criteria that the National Drug Authority has set in some areas is really very hard. The cost of setup is hard, and so the cost of compliance is hard, and that means for some way or the other, it affects the price and therefore affects access to the poor. And then, of course, getting qualified staff to go and work in some of those places become hard. So as we look at how to make things easy in terms of access to the product through e-commerce and all that, the other, in terms of equitable access, then we leave out the other population that is not able to use those platforms. Thank you.
That's a very good point, Edson. Verna, anything to add?
Well, I totally agree with what you said, Edson. It is really, here in Nepal, we are not at that level where it's what is the main problem with e-commerce and so on. Of course, we need to regulate it because it is also relevant here, but it's just getting access and equal access. One of the things we are moving towards is trying to develop guidelines for GPP. They don't exist. And in the past, we have also not had any segregation between wholesalers really and pharmacies. So, and I think that was also the case longer back in Uganda, where pharmacies or wholesalers, they could sell to patients or to other pharmacies and so on. It was really a messy business. And the main thing was that the wholesalers did not play the role they were to play in ensuring quality of medicines and in traceability. And I think when you, Catherine, mentioned quality as one of the issues, I think a country must tackle the good storage and distribution practices and regulate the wholesalers even before they really start moving towards the retail shops. I think also very often, not in Uganda, but in many countries here in Nepal also, because the problems are so many and the challenges are so big, the public sector pharmacies are totally neglected. They are never inspected. They are not regulated in terms of good pharmacy practices. So that was what started in Uganda, actually before that in Zimbabwe, but where the idea was to let's regulate equally private and public sector retail pharmacies. So I think that's it, very important not to forget the public sector pharmacies also.
Yes, the approach needs to be comprehensive. I'd just like to encourage the audience to go ahead and put your questions in the chat and we'll try to answer them as we go along. Sham had a question about the rural communities, and I see Edson has touched on that. But I want to go back to a theme that I see emerging here, and I think it's around this balance, or you could argue it's a tension, right? So on the one hand, you want to have stringent regulations to ensure that you have these, quality services, you have quality products. But at the same time, if regulations are too stringent, then you have an issue with getting these retailers to get started, because it almost becomes a bit of a barrier of entry. And Edson, you talk about this, in like rural areas, getting these retailers set up, the costs associated in making sure that they meet regulatory compliance. Berna, you touched on this in the case of Nepal, where some of what you consider as critical indicators for compliance, if you make those all critical, then no facility would be in compliance because of what the situation is currently on the ground. And so I wanted to ask if you can speak a little bit more, starting with you, Edson, to about this tension and how you see the potential to overcome, where you are able to ensure some basic standards without it becoming a barrier to ensuring access. Over to you, Edson, and then we will turn it over to Birna for further exploration.
Yeah, thank you, Tamara. Yeah, we have a catch-21. Yeah, you want that the facility is able to provide quality services to all clients across board. But then on the other hand, you have that one comes with a huge cost of setup. So how do you balance the two? Yeah, from the side of Uganda, we look at the minimum. Okay, what should somebody have? What are the options? I mean, if it is about having a ceiling, and I think Bina did this with the SURE project and all that, you can have low-cost ceiling for now. So the balance, I think, in Uganda has been struck through the National Drug Authority having some compromises on regulation, what things I must and what things can be worked on as you go. And Muhammad, we talk about more. We also have, for example, wholesale retail pharmacies, the ones which have run both operations. And those we are targeting, those had to insufficiently served areas. So the regulatory body, the National Drug Authority, has made, though we have the guidelines there, but the applications for license are handled on case by case, whereby the inspector is able to gauge and look at the circumstance, look at the coverage, look at the need, and then make some decision based on that. So I think Mohammed could add more about that because he's directly involved.
Okay, over to you, Mohammed, and then we'll skip over to Birna because she's talked a little bit about the gradation of DBP implementation. Mohammed?
Thank you, Tamara. Like Edson said, it's a compromise. We try to look at the objective and see that even when we make that compromise, it does not compromise the quality of the products and the services. So it goes also goes through dialogue between the different agencies. We have an agency called Uganda Pharmacy Owners Association, which brings together all pharmacy owners and operators. So we dialogue with them to see. We continue to review our guidelines every 3 years, sometimes even earlier than that, to see where those pain points are, and we try to adjust some of the administrative requirements to see that people can be able to set up outlets and then continuously monitor them to see that they improve. But just to diagnose a little bit from that, I must say that there are also other challenges that may not necessarily be within the regulation or, but environmental challenges, which are beyond both the regulators and operators, like the IT penetration. Sometimes the difficulty in ensuring that all medicine outlets can be able to monitor their stock and who they sell to is an issue of what access they have to those systems that can help them too. The other things that also come from other industries that affect us, related industries, I can say for regulation of clinics and hospitals, it has also been a bit of a challenge where you have clinics that operate almost like pharmacies and pharmacies that operate almost like clinics. So you have that kind of overlap, and it creates some competition, which is not favorable. And you find that it also brings down the services where people become less ethical than they should be just to survive. I know Bina was very interested in that when she was in Uganda. They even funded a study to see the factors that affect why pharmacies do clinical work and why hospitals, whether clinics operate like hospitals, but there are some problems with that and how we can implement it. So those also affect the services, and they become barriers entry. Thank you.
Thank you, Mohammed. Over to you, Birna. Any other thoughts, reflections on this, and especially the case of Nepal?
Thank you, Lukwang, for bringing up dispensing and prescribing doctors and pharmacists. It is really a mess when the professional organizations are not very clear in that separation. But what I really think is important to keep focus on in this discussion is that we can all make regulations, and it's really damaging if the regulation is not implemented. And in Nepal, where the resources are so weak, the regulatory body is so weak, and I'm sure it's like that for many other countries. You just simply cannot regulate. You cannot inspect. You cannot manage in a way. So that means it becomes sort of a society where people do what they want. And the regulation, how good it is just not implemented. And the industry is happy, they sell medicine. The owners, pharmacy owners are happy, they're not really very often inspected. They can sell whatever they want without prescription. And it's really a terrible situation. But there's only one who suffers, and that's the patient. And that's where it's very important for a government to recognize that there is only one place where the patient can seek protection, and that's through policy, and it's through the governance of the government must step in and take that responsibility. And well, they do it because they have a regulatory body, but if they do not give sufficient resources to that regulatory body, nothing can happen in real life. So I think, for instance, we don't have enough pharmacists to have a pharmacist at all those 30,000 pharmacies. So what did Nepal do? Well, they started educating 3 monthly education, and then they became pseudo-pharmacist professionals, they're called, and they could run a pharmacy. That's also better than not having any education. But I think it's really breaking the law in terms of GPP, good service quality. And that's where you see both Uganda and also Bangladesh chose a line where they say, okay, it's fine. We have some pharmacies who have not the quality of staff that should be there. So they are not allowed to sell all drugs. They are not allowed to sell all prescription drugs. Tanzania did the same. Kenya has also done some. And that's sort of a way of managing to adhere to the rules, but at the same time also managing the situation where you have deficiencies. Another example is you can't inspect every year. And if you are to renew and you have to do an inspection, it's impossible. We have 16 inspectors here or something like that in Nepal. It's just not possible. Okay, so what did Uganda do? They increased the number of inspectors, and then they increased the period to 3 years for the validity of a license. I mean, I think it's very important for regulatory authorities to make sure that you don't break the rules and that you don't force your clients to break the rules. You need to be, and that's what I also like from what was said, you need to sort of be a little flexible to make it work, but make sure you make laws and regulations that are able to be applied to. Because if you start saying, oh, they should all have a pharmacist, and you know it's impossible, then the next other rules will also be broken. And I think it's a slippery slope if that starts, and that's where there needs to be a change. And I think it's the same, the pharmacist has a role to play as a professional body, and that was this, we discussed it a lot in Uganda at that time, that we cannot accept that pharmacists dispense medicines and prescribe medicines. Their role is dispensing of medicines, but of course they cannot stop prescribing medicines if all doctors are prescribing and dispensing. So you have to have professional organizations, both the medical doctors and the pharmacists, to meet and talk and agree. And I think that's what happened in South Africa, that there was this separation of duties. And well, that was what I want to say. Thank you.
Thank you. So the incentives do matter, right? If you have the pharmacist being the prescriber and the dispenser, there might be misaligned incentives there. But then you also really, I think, make the point that we have to be realistic in our expectations. We want to have good standards. We want to have, good quality services, but there's a starting point, and it's being realistic about that to ensure that you don't inadvertently create a barrier. So I think that's very well taken. Just a quick moment to address a question from Mohammed Ibrahim Khan in the chat. How to control antibiotic resistance. As I see, retail pharmacies are one of the contributing factors for anti-AMR in LMICs, where antibiotics are dispensed without prescription, and then patients don't use the whole course of treatment. And I think, especially the point that Bernard just made, has touched on some of this, but I'll just open it up maybe to Edson to speak quickly on.
Yes, Tamara, I had responded to the chat. But I think Dina has raised the issue we have the vice, of course, very prevalent in Uganda, where the pharmacies operate as a clinic. So when the patient comes in, then they do the assessment and then treat. Instead of using the OTCs, then now they go for the prescription-only medicines and give them over the counter. But as Dina has raised, the challenge is that this person is running a business with all these operation costs. So the pharmacy outlet is waiting for a prescription from the clinician that comes with the patient, and then they're able to dispense as per the prescription, but they're not coming in because the clinics are stockpiling medicines, irrespective of the laws are in place, and that is what is causing the pressure on the outlets. But it is very unfair to link the increase in antimicrobial resistance to only prescribing issuing of prescription drugs at the pharmacies. We've seen irrational prescription. I know Muhammad has been seeing these prescriptions where you find around 20 medicines. Then in Uganda here, you find it is stylish to have another ornament, which is a cannula. You find people moving with cannulas around. So if somebody can walk and go to work, why are they on injectables? What is the issue? So there's a lot of also irrational prescribing of antibiotics in the clinics and hospitals. So the increase in antimicrobial resistance is not just about only the device in pharmacies of dispensing prescription-only medicines, not a prescription, but also it goes through all the other practice professionals. That's why I agree with Bina that we need to sit as professionals from the different bodies and then agree on how to move forward as a team. Thank you.
Thank you, Edson. Over to you, Catherine.
Yeah, and this is, thanks for this question, Lauren, because it really touches on so many of the issues we've been discussing today, that tension between access and restricting access, the desire to have everyone have a prescription, but the reality on the ground and the need to make regulations somehow fit with the reality on the ground. I mean, just one thing I do find quite helpful in thinking about this is the WHO aware categories for antibiotics. And this is the three categories that you may well be familiar with. They've divided antibiotics into access, which is the ones that should be widely available to many people for common conditions, watch, and reserve. And so at the other extreme, reserve are ones that should be highly restricted. And I think maybe in thinking about what some of the drug shops, for instance, are allowed to sell, perhaps allowing them to legally dispense some of the access medicines, maybe without a prescription, because we know that's what's happening all the time anyway.
Yeah.
But then having very strong restrictions on other antibiotics, particularly the watch and reserve, might be one way to find our balance through this really challenging problem.
Thank you, Catherine. So in the interest of time, Edson, go ahead, please, quickly.
Just a quick one. In Uganda, these Class C outlets, which you call drug shops, were meant to be a stopgap measure. That when a pharmacy is open now in the rural setting, in the insufficiently served places, then the drug shop should either upgrade into a pharmacy or move deeper inside. So if the laws are there, only that implementation became hard because of lack of political support and all that. But otherwise, we can improve on this if we let the law work.
Thank you. So a stopgap measure has become somewhat of a permanent measure because of the market dynamics, I take it. Yeah. So we have about 6 minutes to go, and I would like a chance for each of the panelists to just quickly, because ultimately, as Berna said, this is about the patient, right? And, you know, how do we ensure equitable access? How do we ensure that they have access to quality pharmacy services? And so I want to give each of the panelists, say, a minute and a half to just quickly touch on, based on our discussion today, what do you see as the implications for equitable access, especially among the rural and urban poor? And if there's one critical element or factor that national governments need to prioritize in their policy agenda to improve the quality of services, what would that be? And I already know Berna's answer is going to be regulation. starting with you, Berna.
Well, in many countries, and especially also now here in Nepal, regulation is the most important. And I think it starts and it also ends with regulation. But if the political leadership is not there, if the resources are not there, we can say regulation, but we can't really then do regulation. So it's critically important that a regulatory body needs to have access to sufficient resources. And one way of doing that is to create an autonomous body or semi-autonomous. I have not come across, but I'm sure in more wealthier communities or countries, they can easily be under the government. But when the government budget is very limited, this is where the constraints are to ensure sufficient resources. And when we talk about pharmacy services, a critically important point is the inspection. And that has both to do with quality of inspection, but also number of inspectors and being able to, on a regular basis, inspect and penalize also, because it's a follow-up also. So regulation is more than just doing inspections. It's also ensuring that the information from these inspections are used to follow up and work with the associations to make things happen, because there needs to be building capacity. And that's where in Uganda, the collaboration both between doctors and pharmacists, and also between the pharmacy associations and the regulatory body and the Ministry of Health, has been very, very strong. And I think that is critically important, that there is a strong unit in the Ministry of Health for pharmacy services, so that they can be part of the policy making and say, okay, we need to put more resources into regulation. We need to move in that direction. So leadership starts, to me, in my opinion, with the Ministry of Health. And if they don't have a strong pharmacy unit, it's very difficult then to also have a strong regulatory body. And it cannot be in isolation. There needs to be strong collaboration. So I think that's for me critically important. Oh.
Thank you very much, Berna. And just to point everyone, there are some resources being posted in the chat. An example of Kenya, for example, on the regulation of pharmacies, and some of the work that's been done on the accreditation of drug shops through an MSH program posted here by Jane Briggs. So just want to highlight that. And Edson, I'll take your chat as your final word on this, given the time. Is that any final words for you in terms of the equity impacts, or what you see as like that one key thing that governments need to prioritize? Over.
Yes, okay, thank you very much. So recently we have identified that in Bangladesh, actually the number of drug shops are very large. And we have got 18.6 retail drug shops per 10,000 population. In contrast, the global median is 2.5. EU median is 3.3. The PAHO median is 2.65. CRO median is 1.73. So in fact, if we have only 4 community pharmacies per 10,000 population, we require only 68,000. And if we actually try to ensure at least 1 community pharmacy in the lowest administrative area of Bangladesh, we still require less than 100,000. But we have got 3 times more. So we want to actually take advocacy opportunity with the policymakers that we should reduce the number of drug shops, and we try to ensure the standards of those drug shops, the regulatory processes, and then within the capacity of the drug administration, actually it will be able to actually monitor this. So I think this is the critical point we have observed, and we'll actually take this message to the policymakers. Thank you so much.
Thank you very much, Azad. Any last word from you, Mohammed? And we're right almost at time. We want to give Catherine a chance to close for us. So quickly over to you, Mohammed.
Thank you, Tamara. If you ask me that one thing that we can do to help us with the GPP, I would think of an effective health insurance system. I see most of the motivations for a poor GDP or the GPP or services because of profit from providers and lack of finances from the population. If you can have a good health financing system that ensures that we have outlets where pharmacies are integrated, people can get access to pharmacies in all the places because the system can fund them to be there, and they don't have to use their money out of pocket to pay for services. Even the decision will be based optimized because of the packages, and they will be based on evidence to ensure that the patients benefit a lot. Thank you very much.
Thank you, Mohammed. And over to you, Catherine, for any final summation or global outlook on this topic. Thank you.
Well, fantastic. I just want to say it's been such a rich discussion, and it's been really inspiring to hear from all my fellow panelists. I don't think I could summarize everything everyone said, but I have a few take homes. I think we've really, emphasized how important the pharmacy sector is already in providing equitable access to healthcare, but we've all acknowledged the massive gaps there are in achieving GPP. So we have a big agenda ahead of us. For me, a really important first step is making sure you really understand your local landscape in pharmacy. So what type of outlets, what is the market share of different type of retail outlets? Who are they serving? Which kind of income groups? How is that varying between urban, peri-urban, rural areas? How is it changing? Crucially, how are the new digital developments affecting that? It's been fascinating to hear about regulation. I feel we've had quite a sophisticated discussion on regulation today, which I've really enjoyed. So talking about the importance of resourcing, but also talking about getting smarter with our regulation. And I think that's so key. So it's been great to hear about the traffic light system in Uganda, which allows you to make your inspections more risk-based. And I think Sham was also, they've got the ABC system, sounds a bit similar in South Africa, was mentioned in the Q&A. So I think using some of these risk-based strategies or other strategies that can make it more efficient to regulate are really important. I've also just, I really feel it's important to hear people discussing those pragmatic balancing act you have to do between trying to get high GPP, but not wanting to make it practical and, as Bernard said, achievable. There's no point setting a load of regulations that everyone is going to flunk. And just understanding that how critical that work is by regulatory authorities to try and work out that balance. And I think we've had some great examples of that. So I've really appreciated that. And then also realizing that it's not just regulation, we also want to do things that give positive incentives to providers, whether it's about encouraging, educating, motivating. It's been really good to hear about pre-service training. Let's get them young and make sure they have the principles they want them to have. So it's great to hear about that. And we need to think about new ways of training people. Again, we need to get smart, we need to get digital. I very much take the point that a lot of the rural population won't have access to the web, but most drug shop owners, I very rarely think you can find a drug shop owner these days without a mobile phone. They'll definitely all have them. And I think soon they'll all have smartphones. I mean, maybe if we're talking the next 5-10 years, they're all going to have them. So we really need to be thinking about that technology. And then finally, of course, it's been really helpful. People who have brought us back to think about the patient, think about equity, and think about financing. And we could do a lot of work to create perfect GPP facilities, but if they're not going to be accessible to our rural and urban poor target groups, then that's not going to be the solution. So we always need to be coming back to the patient. So thank you all so much. Great discussion.
Well said, Catherine. Well said. Thank you to our panelists. Thanks for a very rich discussion. And I think you've done a really good job of highlighting here the need, both the complexity and the pragmatism that's needed in terms of trying to help and improve pharmacy practice. Just a quick plug for the webinar series. You know, this will be happening weekly. So we have one coming next Thursday, and that one is going to be focusing on just highlighting some of the interventions, some funded by USAID at reaching, you know, the rural poor and the urban poor with good quality pharmacy services. So that's on the radar for next week. And then we've posted in the chat a link to the rest of the series. Thanks again, everyone, for your attention, and special thanks to our panelists for a really nice and engaging and rich discussion today. Take good care and stay well. Bye-bye.
Bye-bye. Bye-bye.